We're going.
Yep.
Yeah, it's recording.
Perfect. I thought it had. Right. So I'll just give it a few minutes for everyone to join. You can see the numbers ticking up very nicely there. Headed towards the 300.
Gosh.
So.
The hot topic.
Yeah, it obviously is the hot topic.
It's like it's a new vaccine in the country or something.
Anyone would think, yeah, anyone would think it was new information. Right. 378. Of course, there will be a lot of people that have logged on to watch it later. Just give it a few more minutes as we're still getting people joining. But I am conscious that we've got a lot to get through, so. Okay, let's make a start. So kia ora, everybody, welcome. I'm Jane Morfitt. I'm the COVID Clinical Education Manager, and I'm joined today by Dr. Joan Ingram, who is one of our medical advisors. Joan's an infectious disease physician, and she's got an interest in travel and tropical health, although at the moment it's COVID, COVID and yet more COVID. So also I'm pleased to have with us today Lisa Sellers, who's one of our education facilitators, Melanie Miller and Olivia Haslam, who are regional advisors. They're going to help us with questions and answers and some of the behind scenes bits of the webinar. So just a little housekeeping before we start. The webinar will be recorded and will be available on our website alongside a range of other webinars, including yesterday's one on booster doses. We don't provide certificates, but we do encourage you to download our webinar reflection form, so you can log your attendance at the webinar and also use it as evidence for your professional development. This form can be found on the AstraZeneca webinar page on our site. So just where you logged in to register for the webinar, we've put the reflection form in there as well to make it easy to find. And lastly, just to let you know that the chat button has been disabled, but there will be an opportunity for questions. So please type them into the Q&A button at the bottom of the screen, and we'll try and answer as many as possible. If we don't manage to get to your particular question, just a reminder that we do always, of course, have email question option at 0800 immune at auckland.ac.nz. So you can always at any time type in clinical questions there if they're not urgent ones, rather than ringing us. We will be compiling a list of all the questions that come through, and common ones will be added to our question and answer as on our website in the near future. Right, so no further ado, I shall hand over to Joan for the first part, and I'll cover some of the practical issues at the end.
Great. Thank you, Jane. So this was going to be an A to Z of AstraZeneca vaccine, but in the interest of time, we're not going to say the information that's in the teaching course, the online teaching. That includes things like how the vaccine works and the components in the vaccine. So we're not going to talk about those in detail. I'll mainly talk about the efficacy and effectiveness, and then a lot about the safety, contraindications and precautions in pregnancy, and then its use in mixed schedules, as many of the people who will be having it will have already had a dose of Pfizer. And then Jane will talk about the other practical issues before we do questions. So a little bit of background, this vaccine was developed by the University of Oxford, and then they got a partnership with AstraZeneca. I think it's a Swedish firm. And all along their intent has been to sell it as a not-for-profit vaccine. It's fridge stable, meaning it's much easier to transport around the world than the mRNA vaccines. And so it's about $4 a dose, I believe, for lower income nations. So it's a fraction of the cost, evidently, of the other vaccines. And it's been widely used in UK, Canada, Australia, and in fact, 2 billion doses have been released to over 170 countries since its rollout. And 2/3 of its use has been low and lower income middle countries. To date, it's estimated to have prevented 50 million COVID cases and 5 million hospitalizations and more than 1 million deaths. So globally, we owe it a huge gratitude. Like Pfizer, it has a variety of names. The AstraZeneca are the producers, but its trade name is Vaxzevria, but it's also manufactured as Covishield in India. So its trial name was Chadox 17 recombinant, or AZD, and it's a non-replicating viral vector vaccine, and all the information about that is in the online training. So we'll leave that to you to learn about. So MedSafe approved it in July, and we're going to have 100,000 doses available from the 29th of November, so very soon. It's not going to be available at all vaccination sites, and bookings will be required, probably most. So how effective is it? This is a graph from the phase 3 trial, where 17,660 people received the trial vaccine and 855 placebo. There were 203 events. Each little line here is a case of symptomatic illness, 73 in the AstraZeneca recipients and 130 in the placebo. Remember, there were many more placebo vaccine recipients than placebo. So this showed an efficacy of 74% in the trial for symptomatic illness. And more recent data, so including with Delta, this is the week 40, up to week 40 for the UK, compares AstraZeneca and Pfizer, because as you know, they use both, probably about half and half numbers in their country. And you can see both vaccines remain very effective for hospitalization and death. AstraZeneca is perhaps a little less effective at reducing any infection or symptomatic illness than Pfizer, but still, far better than influenza effectiveness. It's so hard to measure the impact of vaccines on transmission, because you only know about transmission if you do repeated tests to detect infection. It's, could be there even if people have no symptoms. So transmission is a lot harder to measure and count than, say, hospitalizations. And if there's so many variables, like the time since somebody had their vaccine, the contact type, so we know that household transmission is far more risky than, something brief, duration, and the presence or absence of symptoms amongst the person transmitting it, sneezing and coughing really increases spread, and even the age of the source person. It seems that the older you are, the more likely you are to transmit it. But this study here is just one example of the transmission studies. It's again from England and NHS, where they found that 49% of contacts of unvaccinated index cases were PCR positive, compared with 30% and 23% of the contacts of fully vaccinated, infected AstraZeneca recipients or Pfizer recipients. So again, maybe Pfizer's a little better at preventing transmission. Sorry, those were cases that transmitting it, whether they'd been vaccinated or not. Yeah. So now moving on to safety. So again, this is a reactogenic vaccine, just as the Pfizer one is. Up to a 74% report sore arm, and a similar number might report systemic adverse events. They're very usually mild or moderate and resolve in 1 to 2 days. However, unlike Pfizer, where the adverse events are higher after the second dose, for AstraZeneca, both local and systemic reactions are greater after the first dose, so milder and reported less frequently after the second dose across all age groups. So it's the opposite to Pfizer. When having a third dose after 2 previous doses of AstraZeneca, it seems to be very well tolerated and even lower adverse event rates than the primary dose again. So as you know, in Australia, they've got this active monitoring where people are sent a message after their vaccination to ask them how they're feeling. And they've had responses from over 500,000 people for first dose and a wide range of ages. But 56% said they'd had any adverse event after the first dose, down to a quarter after the second dose. 1 in 100 had to seek medical attendance after the first dose, less than that after dose 2. But much like Pfizer, around 20% had to interrupt routine activities such as school or work, but this time it was after dose 1 instead of after dose 2, as it's seen with Pfizer. And this is a graph showing the symptoms. In blue are the symptoms after dose 1, and in green after dose 2. So you can see big difference between first and second dose, but local reaction, fatigue, headache, joint pain, and fever are the most common symptoms reported. Anaphylaxis is less common after this vaccine than after the Pfizer one. And the big safety signal identified earlier this year is this syndrome of thrombosis and thrombocytopenia, called TTS. You might see it also abbreviated VITT or something, vaccine-induced thrombosis and thrombocytopenia. So it was noted that people were getting serious blood clots in unusual sites. So the cerebral venous thrombosis, splanchnic vein thrombosis, so the blood vessels to major organs, the gut, and arterial thrombosis associated with thrombocytopenia were reported when the vaccines really got used widely after both the Janssen, which is another viral vector vaccine, and this AstraZeneca one. And now multiple surveillance systems have confirmed this association. The mechanism by which they trigger this is still not perfectly clear, but it seems that they trigger something very similar to a condition, a rare condition that we've known about for a long time called heparin-induced thrombosis. And it's also named autoimmune heparin-induced thrombosis, where antibodies against platelet factor 4 make these complexes that activate platelets. And the activated platelets cause thrombosis, and also the platelets get consumed. So there's thrombocytopenia. So the risk in Canada has been 1.3 in 100,000 doses, Australia 2.4 per 100,000 individuals under the age of 60, and 1.8 if they're over 60. In the UK, 1.48 per first doses. They again found 2.1 per 100,000 in the 18 to 49 and lower over 50. So I think it would be fair to say there's a range, but it's probably 2 per 100,000 if you're under 60, and somewhere in the 1s per 100,000 for over 60 years. We do know for sure that it's definitely a first-time vaccination event. It's 10 times less after the second dose. So in UK, you see it was 0.19 per 1,000 second doses. So the main risk for increasing somebody's risk, the main factor is a younger age. So, and anyone who didn't have it with their first dose, if they're needing 2 doses, can be reassured about the risks for their second dose being far lower. This is a graph from Melbourne, there's 2 tiers here. Tier 1 is a more severe form of this with very aggressive clots in most unusual places. Tier 2 is more common clots such as leg clots and less aggressive. But anyway, they did see a higher rate in 10 to 19-year-olds. This will be very small numbers, but I guess we could say the risk might be higher than 2 in 100,000 for some groups, but it's hard to know exactly how much higher, but a little bit higher. So cases typically appear between 4 to 28 days after the vaccine, but evidently they might take some days to present, so really up to 42 days you would be alert to it. And it's a very wide spectrum of severity of illness, as well as a wide spectrum of presentations. But the tier 1 ones can be very aggressive clotting and hard to turn off. So the younger people tend to have the clots in unusual places, and older adults tend to have less severe ones with typical clots, such as DVT and pulmonary embolism. So initially, when we didn't know anything about it, the case fatality rate was very high, unfortunately. Now it seems to be lower with better recognition of the syndrome and knowing how to manage it. Overall, the UK have had a fatality rate of 17%, but in Australia it's 3%. But people who survive it may have complications. So thinking about how somebody might present, it's a headache that comes on a few days after the vaccination that really is persistent, and it might be worse when lying down or accompanied with symptoms such as nausea and vomiting, and other signs of raised intracranial pressure or focal neurological deficits such as weakness on one side, or speech problems or seizures. And then other symptoms or signs suggesting thrombosis somewhere in the body. So abdominal pain might suggest the splenic circulation thrombosis, or chest pain suggestive of pulmonary embolism. And then finally, symptoms or signs of thrombocytopenia could alert you to it. So if we're talking to patients, we might say a headache that just is worse when you bend over or lie down, or you might say an unusual headache that is different from usual, with symptoms such as blurred vision, difficulty speaking, weakness, drowsiness or seizures, and then or describing the rash that could be, you might see, associated with low platelets. And other symptoms such as sudden shortness of breath, suggesting a PE, chest pain similarly, or leg swelling, or this abdominal pain. And because of the arterial thrombosis, maybe cold, painful limb. Management is very important, and the main thing is recognition of it and identifying it and managing it correctly. So the initial blood test people should have is a full blood count and a D-dimer, and then any imaging to look for signs of thrombosis. If somebody has a low or falling platelet count, and you might want to repeat it, one test alone may not identify it, and an elevated D-dimer, and this is the what you would expect to see, very raised D-dimer. And they can then have a special test for this antibody to screen for it, but you don't wait for that test, you get them seen. Because outcomes are better with early presentation and recognition of the symptoms and the right management. What we now know is that you must not give these patients heparin or platelets, because that's like adding fuel to the fire. So they need non-heparin anticoagulation. This is a paper from the UK showing the relative risks of some of these clotting issues. So in pink, bright pink is what you see after somebody's got an infection. They've got a high risk of venous thromboembolism, cerebral venous sinus thrombosis, strokes, MIs, and other arterial thrombotic events. So we have to keep remembering that this is what we're trying to avoid. You can see, though, that the AstraZeneca and the Pfizer may be associated with cerebral venous sinus thrombosis. And then the risk for AstraZeneca or Chadox here is thrombocytopenia, venous thromboembolism, and other rare arterial thrombotic events is all increased. This is in the context of COVID illness causing it far more. This is a graphic from one of the available resources if you're trying to discuss risks with somebody when they're considering the vaccine. This is Australian, and they have 3 different scenarios in this resource. And our Auckland risk is probably somewhere similar to their medium exposure risk currently. And this is the cases of TTS by age, so the numbers there, and then how many hospitalizations would be prevented by being vaccinated with this vaccine, or ICU admissions and deaths prevented. So not all of these people will die, obviously. There's a small chance of dying now. So this helps people weigh up the relative risks, which are what we have to remember. So another possibility, but extraordinarily rare, is this thing called capillary leak syndrome. It's very rare, but serious, with people having leak from their capillaries, so they get swollen limbs, low blood pressure because everything's leaking out, and low albumin. And in Canada, they've had 2 cases of it amongst 2.7 million doses being distributed. So it is very rare. But I guess it's just something we have to have at the back of our mind, because again, you need to recognize it and manage it. And it is a reason not to give the vaccine if anyone has ever had this condition. Guillain-Barré syndrome does seem to be associated with this vaccine. And basically in the UK, they estimate 38 cases per 10 million vaccinated, so 3.8 per million. So there has not been an association with the Pfizer vaccine, but there is with AstraZeneca. Interestingly enough, there's a massively increased risk of getting Guillain-Barré and Bell's at the same time with this vaccine. So risk 28 times. So overall, the risk of Guillain-Barré is maybe 2.9 or 2.2 relative risk increase. But this is really a very rare thing to happen, but they're seeing it with this vaccine. In Canada, they reported Guillain-Barré onset between 6 hours and 25 days after the vaccine, with a median age of 55 years. And as I mentioned, you can get this syndrome of facial weakness, in fact, both sides of the face, not one side. So it's a very unusual variant of well, in this case, they hardly have Guillain-Barré, but they have distal sensory symptoms and facial diplegia. So it's a very rare thing that may be seen. This is another one of these things, comparing your risk with the illness. So along the bottom here is various neurological conditions that we see with COVID infection. So demyelinating diseases, and I can't see the top of my slide, whoops. Sorry, Bell's palsy, Guillain-Barré. So they're hugely increased by the infection. All of these neurological syndromes can be brought on by the illness. However, here you see the risk after AstraZeneca for Guillain-Barré clearly increased, but really nothing else neurological, and neurological complications after Pfizer's, not clearly increased. So this is rates of Guillain-Barré, again from Melbourne, Victoria. They've had 23 cases after 3.7 million doses. The next thing it may cause is just a low platelet count, immune thrombocytopenia. It's not a big increase, but a small risk. And again, in Victoria, they've seen 25 cases after 3.7 million doses, and it seems to be more in elderly. So uncommon, but possible. However, it's important to note that anyone with thrombosis noted after the AstraZeneca should be checked for thrombocytopenia. And similarly, anyone presenting with a low platelet count should be checked for thrombosis carefully in case they've got the syndrome. So getting on to contraindications and precautions. So if anyone has TTS after the AstraZeneca, they should not have another dose. People with a history of cerebral venous sinus thrombosis should not either. And people who've had this uncommon heparin-induced thrombocytopenia. I think it's seen not that uncommonly in people after cardiothoracic surgery, but I'm sure the people would know if they'd had it. Then any idiopathic splenic thrombosis, so blood vessels of the mesentery and the liver and the spleen. A history of antiphospholipid syndrome with thrombosis should not have this vaccine. Capillary leak syndrome, as I mentioned, anaphylaxis to a previous dose, anaphylaxis to anything in the vaccine, including polysorbate 80. Actually, polysorbate 80 is in a lot of the vaccines that we give. It's a common additive to vaccines. or a serious adverse event to a previous dose. So if people have had blood clots in typical sites, they can have it, or a clotting tendency that's not immune related, or a family history of clots, current or past thrombocytopenia, it's okay to have it evenly in those on anticoagulant therapy. So there's no evidence that a past history of clots or of any clotting tendencies increases the risk of this, other than those groups that I've already mentioned. Pfizer, is our preferred vaccine in pregnancy. But if they cannot have a Pfizer, then it would be an individual discussion with the person about AstraZeneca. The reason we have concerns more with AstraZeneca is that there's been less real-world use of it that we can read about. I'm sure it's been widely used in many countries, but it's just not so much information available. There's no theoretical or safety concerns associated with it, but it's just the limited data at this point. And also, if the person's already had a Pfizer, as I'm going to tell you about mixed schedules, there's less information. So it's probably not something we're too keen to do with a pregnant person at this stage, but it's very much a risk-benefit discussion. So now, because as you know, this vaccine is an option for all our those who can't have another dose of Pfizer for whatever reason, they will be having a mixed schedule. It's called heterogeneous. I can't even say the word schedule. So, on first basic principles, it's okay to have two different ways of sucking eggs. They end up with the same result. You're making the same spike protein at the antibodies at the end of the day. So with our principles, it's expected that combining them will get good protection. And this is a study comparing different schedules, mixing them up. And here is people that had 2 doses. In this column is 2 doses of AstraZeneca. This column is a Pfizer followed. No, that's probably Pfizer. And this is Pfizer, then AstraZeneca. And basically, you don't need to look at the numbers, just looking at this line here. The antibody titers are better if you have 2 doses of Pfizer, but the cellular response down the bottom here is better if you have a Pfizer followed by an AstraZeneca. So how this plays out in the real world with protection for people with a mixed schedule is still open to debate. We don't have enough studies about this, but this study deliberately gave people a mixed schedule. It's called the COMCOV study, and basically antibodies were a little bit better if you have 2 Pfizer, but the cellular response was better with the mixed schedule. However, we do know that side effects are increased in those who have a mixed schedule compared with the 2 doses of Pfizer. So along here is 2 doses of a Pfizer followed by a Pfizer. Down the bottom is a Pfizer followed by an AstraZeneca. And here you can see the side effects are increased. This is dose 2, and you can see higher rate of side effects. I'm sorry, I can't read the top of my slide, but I think this is arm pain, is it maybe? Yeah, these are systemic. See, these are local side effects, so they're probably not increased. But here, the systemic side effects are increased in those that have the mixed schedule. So here you can see more fatigue down the bottom. You can see more headache compared with 2 doses of Pfizer. You can see more malaise and muscle ache. So it's usually mild, but there are more reports of symptoms following a mixed schedule of these 2 vaccines. So in summary, it's a widely used and effective vaccine. It does have this unusual syndrome of thrombosis and thrombocytopenia, and it's important to identify it and manage it correctly. So people need a risk-benefit discussion before having it. And it does have higher reactogenicity when used in mixed schedules. So I'll hand over to Jane.
Thank you very much. So if you stop sharing your screen, I'll share mine. There we go. Okay, so thumbs up, Joan, is that working all right?
Yes.
Yep, lovely. Okay, thank you. So as Joan said, we are expecting that this webinar will be a supplement to the online training. There just isn't time to cover everything, and we did want people to work their way through that. But there are a few key points that I wanted to cover, and just a couple of things I wanted to make sure people understood. So primarily, it's that those staff that are actually administering the vaccine and preparing the vaccine, we do really want you to do the online training and print out your certificate. It shouldn't take more than an hour at maximum. And the online training is not suitable for the COVID vaccinators working under supervision. So it's for authorised vaccinators, qualified healthcare professionals, medical staff and such like prescribers. For all of AstraZeneca vaccines, a written consent form is recommended. That's ministry guidance, and it's because of this increased risk of side effects that Joan's just been talking about. So they would like all cases, whether it's mixed schedule or not, that a consent form's used, and there is a new consent form just being designed that includes AstraZeneca. A prescription is required if AstraZeneca is being used as a mixed schedule, and that's simply because MedSafe hasn't approved mixed schedules. There isn't enough data there for them to approve mixed schedules. Plus, I don't know whether there's a will to do that. They usually look at each vaccine individually. We've produced a selection of resources. We've coloured them in this dark sort of red-orange colour to try and match the cap colour on the AstraZeneca. You'll notice that there's 2 vaccine preparation documents. Now that is totally intentional. We have a small A5 one that we hope you will just pop on the desk next to you when you're preparing your vaccines as a quick aid memoir. And then there's the more detailed A4 version that you're used to with Pfizer that gives you some of the background information and a little bit more detail around how the vaccine's being prepared. We are recommending that the vaccine's stored in the fridge. That way we will get 48 hours worth of use out of it. So it's an important difference there. So each vaccine dose is drawn up and then the vial goes into the fridge. The vaccines can go into the fridge as well. They can be stored in the fridge and they can be given at fridge temperature. You don't need to allow any time for them to reach room temperature. So a couple of quite important differences there. We also have a vaccine record sheet. And this is quite important. This record will help you to log the number of doses and also to calculate the time that you have available for your vaccine. Because one of the other differences with AstraZeneca is that when you first take the top off the vial, you have 48 hours, provided it's stored in the fridge. However, when you prepare a dose, you have up to 5 hours where it could sit on the desk or it could go back in the fridge. The issue is that the 48 hours will always take precedence over that 5 hours. So if your vial is due to expire at 10 o'clock and you draw a dose up at 9 o'clock, you do not have 5 hours, you just have 1 hour. So the labelling of the vaccine is really important. It's also really important that you get the labelling right because sites will be delivering Pfizer vaccine as well. So we want to be really sure it's clear the differentiation between the two. There are different syringes being delivered with attached needles that draw up to 5 mils. We expect the majority of them will be the orange Flu Plus needles and syringes. You will have the option, of course, for larger clients of using a 38mm needle and you then just use a standard 1 mil syringe. But most times the syringes will look different as well. And again, that's an extra safety feature. This is the new consent form that just came out yesterday. And as you can see, it now covers information about Pfizer vaccine, but also about AstraZeneca. And you can download that from the ministry website. We'll put a link to it on our website as well. And it's got sections so you can tick off whether it's first or second or mixed dose or whatever. So quick summary of some of the differences. It's no dilution needed with AstraZeneca. It's a 5 mil dose. 10 doses per vial. You can occasionally get 11 if you're using LDS needles. After drawing up, ideally we'd like you to use it within an hour, but you do have up to 5 hours and that can be at room temperature, but equally you can store it in the fridge and use it straight away. It's a 2-dose schedule, but a minimum of 4 weeks apart, not 3 weeks. If you're giving it after a dose of Pfizer, it would be 4 weeks after the Pfizer. stable for 48 hours, as I've mentioned, and I've mentioned the syringes and needles. The other important difference is that it's for those 18 years and over, and it's not our vaccine of choice for pregnancy. So we've got a fact sheet on AstraZeneca as well, and the other resources on our website. So I think, oh, just one other point I wanted to mention. The screening tool was not embedded in the training, and that was because we hadn't had final sign-off on the wording of it. It has been signed off. It is under AstraZeneca tab on our website now, but you may notice if you're good at details that you'll actually see we've got version 2 up. There is one small change being made today, and it's just to give a little bit more detailed guidance around how to assess somebody who has had previous clots. So if you've already downloaded a copy of the screening tool, please get the latest version, version 2, download it off our website and make sure that's the one that's being used in clinics. And if you couldn't find it when you did the training course, I apologise. There was a problem with the link on the website, but it is on there now. I checked myself. So please find your screening tool. It's designed, again, to have as a quick reference document beside you when you're discussing cases with consumers. Right, so that's my bit done. So now we'll open the discussions for any questions and invite our colleagues back to join us. Okay, so Olivia, do you want to?
Hi, everybody. Yeah, sure. You're still screen sharing though, Jane.
My apologies, thank you.
I'll start with some easy ones. Can a provisional vaccinator give AstraZeneca, Jane?
Yes, they can, provided they have done the training course and got the certificate. Same as with a fully authorised vaccinator.
Okay, and how will sites be selected to offer AstraZeneca doses?
DHBs have been deciding which sites have had the opportunity to put their names forward. And I understand decisions have already been made as to which sites are having AstraZeneca.
Yeah. So I believe the deliveries tomorrow.
Yeah, there are certain criteria that they had to meet. For example, they do need to be able to have a prescription, somebody available to sign for prescriptions, because that's one thing I maybe didn't mention in enough detail, actually. If you're giving a mixed schedule, you do need to have a prescription. And so these sites should have somebody available to help with writing prescriptions.
Yeah, so that was one of the questions. If a person doesn't have a GP, what is the best way to get a script that is needed for a mixed schedule? Will a visit to a GP that they are not enrolled with, will that be free or paid for under the COVID response, or will they still have to pay a surcharge? This could be a barrier. Okay, so if a patient wants AstraZeneca vaccine, they go into Book My Vaccine and they will get a choice of which vaccine do you want. They can book AstraZeneca and that will direct them to a limited number of sites, but those sites will be set up to be able to provide a script. So it won't be an issue. And there is funding associated with it equally if they did go to a GP. Okay, and another prescription question. Does anyone who gets an AstraZeneca require a script or only written consent? Okay, so it's only written consent if it's the first dose of AstraZeneca. So for example, somebody that was vaccine hesitant over an mRNA vaccine or had history of anaphylaxis to something that was in the Pfizer vaccine, if they come to have an AstraZeneca vaccine, it's approved by MedSafe, so there is no need for a prescription, just a consent form to show that you've had a discussion about the risks and benefits. And following on from that, what is done with the script? Is it uploaded into CIR? Okay, so yes, best practice is that it's uploaded into CIR alongside the consent form. I know that some sites have challenges associated with that, so I believe that some people are storing the information as medical records, but obviously there are challenges associated with that, and there's importance of maintaining those records as they are clinical records for the appropriate length of time. Okay, and I've just got one more admin question, and then we'll go over to Joan. Just confirming regarding provisional vaccinators, can they give AstraZeneca and can they check AstraZeneca? If they've done the appropriate online training, then yes, they can. Obviously, we're all starting from the same point. None of us have used it before unless we've got people coming in from abroad. So working together and building confidence about drawing it up. But it is already diluted. It's actually easier than using the Pfizer vaccine. And vaccinators under supervision, will they be able to give the AstraZeneca?
We don't anticipate that in the short term anyway. We're not thinking the numbers that will require AstraZeneca would be large enough to warrant training COVID vaccinators working under supervision into this extra skill base. So no, at the moment, it's not part of their skill set. They're not taught to do it. And we're not, it's very clear on the AstraZeneca course, those of you that have already done it, that you do have to sign to say that you are a qualified healthcare professional before you access the course.
Yeah, fantastic, thank you. So Joan, how will people from Australia who have had AstraZeneca be treated in New Zealand? Would 2 Pfizers be a quicker option? So maybe they're referring if they've had 1 or 2 doses of AstraZeneca overseas. What's the best course of action? Continue with AstraZeneca or go mixed?
I think they could do either, probably. Yeah. I mean, we know their risk from the AstraZeneca vaccine is very low for the second dose for the TTS. So, I mean, AstraZeneca is a good vaccine. So I'd have another dose of AstraZeneca, I suppose.
I think the important thing is that those doses that they have already had count. So it's not like they're starting from scratch. So if they'd had 1 AstraZeneca, there would then be that choice for the second dose, but they certainly wouldn't then need 2 Pfizer vaccines if they've already had 1 AstraZeneca. Same as if they'd had 2 AstraZeneca and then 6 months later they need a booster dose. But you wouldn't start with 2 new Pfizers. If they've already had the AstraZeneca, it counts as being vaccinated.
Yep. So regarding anaphylaxis, Joan, one of my patients has a history of anaphylaxis and is reluctant to get the vaccine. Can we safely say that AstraZeneca would be suitable for her, given the fact anaphylaxis is a rare side effect, especially compared to Pfizer? So I don't think this is in reference, they've had no COVID vaccines, but they've got a history of anaphylaxis. Which is the best out of the 2?
Well, probably AstraZeneca, but you know, most people can safely have the Pfizer too, unless they've got pig allergy. Yeah.
So I think it would be a case of looking at what known
Exactly.
triggers were to the anaphylaxis and looking at the ingredients in the vaccines.
Seeing which was better of the 2. Yeah.
But there have been a slightly increased number of cases of anaphylaxis to people with a history of anaphylaxis that's not relating directly to any components in the vaccine with the Pfizer. So that's possibly what they're relating to in that question. So obviously on an individual basis, review what's in the vaccine, but maybe the AstraZeneca, as you say, Jane, might be the better option.
Yeah, so in summary, AstraZeneca has a lower rate of anaphylaxis than
Correct.
Pfizer?
Yeah,
I think it's
check that there's nothing in it that the patient's allergic to. Common sense.
If they've got a history, yeah.
Okay, fantastic. Joan, you mentioned safety in pregnancy and the whole risk and benefit. Pfizer is preferred because we've got more data, but what is the data of AstraZeneca in breastfeeding patients?
Breastfeeding it should be all right. Yeah, there's no reason to worry about it at all.
Okay. Next question, client has a history of GBS. I assume the Pfizer vaccine is preferable?
Yes, it would be. Yes, there's one study from Israel looking at people who'd had past GBS and giving them the Pfizer vaccine, and I think 1 person out of 4,000 had a mild reoccurrence of symptoms. So yes, and Pfizer does not seem to bring on Guillain-Barré.
Okay, lovely. So this is a good question. The training mentioned you get better immunity from a 12-week gap from dose 1, dose 2 of AstraZeneca, but then the minimum is 4 weeks. What gap are we recommended to encourage for our patients?
I think it depends a bit on where somebody lives, you know, but this time I think 6 weeks plus is better than 4 weeks for AstraZeneca, probably between 6 and 12. Yeah, so I don't think we know, you know, it's a risk benefit, you know, they need to assess where they live and what the risk of COVID in their community is. So I might have it at 4 weeks if there was COVID all around me, but I would perhaps wait 8 weeks if there wasn't.
Yeah, that's a nice way to put it. There appears to be an increased amount of clinical side effects from the AstraZeneca vaccine compared to Pfizer. Do you expect some pushback from clinicians or general public with the rollout of AstraZeneca?
I don't think it is a rollout of AstraZeneca. It is an alternative option. The programme for New Zealand is Pfizer. We think it's the best vaccine. It's been selected. We're very lucky in New Zealand to have it as the main vaccine. But for some people, for various range of reasons, it may not be the vaccine that they want to have. So the government was keen to have an alternative vaccine. And it's because it does have these challenges that you have the consent form and the discussion around it.
Yep, so we've got some more questions regarding mixed schedules and scripts and consent forms. So we've already been given mixed schedules when we've had overseas patients come in where they've had, say, 1 or 2 doses of AstraZeneca overseas. They've come into New Zealand, they've got Pfizer. So we have been given mixed already. Does that mean that the advice around overseas doses will change? What do we do with that? Jane, do you want to do that one?
I think that's one that will no doubt evolve. But the guidance is still in the handbook at the moment. We're following that guidance, which is that anyone coming into New Zealand with a partly completed schedule can complete the schedule using AstraZeneca, using Pfizer. If we have AstraZeneca, or once AstraZeneca is available, if they would prefer to complete with the same vaccine, then that would also be an option.
Okay, so just some admin sort of preparation questions for you, Jane. So can we put the drawn up vaccine after 5 hours out and use it up to 48 hours? So can you clarify that rule around 5 hours and 48?
Of course I can, yeah. So you could have done it as well, Olivia.
I recited in my sleep. So basically you take the cap off and it's now good for 48 hours if you store it in the fridge. If you draw up doses, you can keep those doses in the syringe for 5 hours at room temperature or the fridge. But when you're filling out the expiry, which is going to be labelled on each syringe, you're going to look at the use by date, which is 48 hours from opening, or the 5 hours from which you've drawn up. Whatever occurs soonest is what you goes on the label. You've got to think away from Pfizer, where it was they were one after the other. We've got 31 days in the fridge, 2 hours warming, 6 hours to use a syringe. This one, it's going back to, you got 48 hours, and that shortens to 5 hours if you're keeping it in the syringes or at room temp.
Never goes above that 48 hours total time. Yeah.
And it says not to shake the vial, but there's no advice regarding inverting. So can we maybe clarify about dilution and inverting versus AstraZeneca?
Yep, go for it. Olivia was one of the writers of the vaccine prep sheet. So.
Yeah, so this vaccine, it's ready to go. It's just like all our other scheduled vaccines. It's going back to thinking about all our other vaccines. So don't shake it, don't invert it, don't dilute it. Get it out of the fridge, draw it up, put it in your patient, put it back in the fridge. That's all, okay? We're going back to nice, simple, basic vaccines. So,
and our preference is that you actually discuss the risks benefit with the patients, make a decision that yes, they do want the AstraZeneca, get it out the fridge, draw it up, give it, as opposed to having them all set out ready to go. Obviously, in some clinics, if you know you've got a lot of patients coming through who specifically want AstraZeneca, it may be more practical to prepare in advance. But a lot of the time, it will be easier to make sure they actually want the vaccine, then draw it up, put it straight back in the fridge.
Okay, so going back to clinical questions with Joan, a common cohort who are having AstraZeneca are those who have had myocarditis from the first dose of Pfizer. These tend to be a younger cohort of patients, given the nature of myocarditis side effects occurring in that population. I am one of them. According to one of Joan's slides, in the under 39 group, we will have more cases of TTS than deaths or ICU cases prevented. TTS has CFR in the UK of 17%. How do we approach this risk-benefit discussion? My treatment providers have not had this discussion or provided this data. So yeah, like the young people who are getting myocarditis.
I think you need to have the discussion. I think you need to have the discussion. That's why we're providing it. There's a link to that resource, you know, and it's got a graphic or it's got the table. The graphic's another good way. That's in a resource for discussion with people. Yeah, but yeah, the case fatality rate for TTS in Australia has been 3%. So, you know, the 17% includes at the beginning when when we didn't know about management. So it's lessened. Yeah.
Can pregnant women have both doses of AstraZeneca?
Well, I think that's something we need to discuss with the pregnant people. It's
put it this way, if I was pregnant, I would want 2 doses of Pfizer. There's far more safety data. That would be my preference as a clinician.
Yeah, absolutely.
But it would only be people that can't have Pfizer, obviously, even thinking about it. Yeah.
And then looking at the risk factors for that individual.
Yeah, and probably it's better for them to be vaccinated, but it's something that needs to be thought about carefully.
Yeah.
Discussed.
Yeah, it comes back to that. that leads on to this next question. What's the criteria for an individual to get AstraZeneca vaccine? So who qualifies for AstraZeneca, and would there be a choice for people to either choose or decline this vaccine?
Well, that's an interesting one, because what's been publicised that I've seen in media briefings is that it's for obviously those that are contraindicated Pfizer. So if either they were contraindicated the first dose or they've had a severe reaction to the second dose. That's straightforward. But they're also saying anyone that the vaccine order applies to that needs to be vaccinated but doesn't want to have the Pfizer vaccine could apply for an AstraZeneca. And in fact, that group is fairly open. Anybody can go on Book My Vaccine and request AstraZeneca, but it might be when they actually have the discussion, they change their mind and decide they would prefer to have Pfizer. So, but anybody can actually ask, although that's not been widely advertised as far as I can see.
Yeah. Joan, how can I discuss risk of clotting to a patient without alarming them, apart from the fact that the risk is very rare? E.g., do I mention all the symptoms of adverse events like capillary leakage?
I think capillary leakage is a very small print one, but I think they do need to think, be told that if they get strange headaches or bad headaches or any weird neurological symptoms or abdominal pain, that they must see a doctor. So I would talk about those risks, but not. I think the capillary leak is pretty uncommon, and probably most people would seek advice if that started happening.
Mm-hmm. We have tried in the screening tool to give you the basic information. So you've got the key questions that you need to ask, the responses that you'd have relating to those questions, and then also some summary information, a little bit more around these issues. It is, to be supplemented by this webinar and further training, obviously, but we are, of course, always on the end of the phone as well. So, some of the things like post-vaccine advice and such like that is different for AstraZeneca, I've put specifically in the screening tool so that you've got that to hand as a reference. So hopefully that will help.
Yep. And can you give AstraZeneca with any anticoagulant medication, e.g. heparin infusion or certain anticoagulant medication?
With other anticoagulants, but I would have to check about heparin infusion. I think that's quite unlikely that you'd be vaccinating them when they're on a heparin infusion. It's not that common. It's just at the start of anticoagulation usually, isn't it?
Yeah, I mean,
there's no reason not to.
It's the same as for the Pfizer vaccine in terms of the bleeding risk. The guidance in the screening tool is the same for both when it comes to people on anticoagulants or with clotting disorders.
So is it safe for those with low eGFR in case of a renal problem, so kidney function? Is that okay, Joan?
I didn't see anything against it for that group. Yeah.
Okay. And if in doubt, we've always got the 0800 immune line that you could go.
I mean, I'd want to check the data sheet. Actually, I haven't actually read that.
I don't remember. Reading renal.
It didn't leap out at me, so I guess it's okay. But I'd rather check.
Yeah. Okay. And just to clarify, are we now practicing heterologous vaccination here in New Zealand?
For people who can't have a second dose of Pfizer, yes. And obviously, as somebody pointed out, we've been doing it ever since people started coming into the country with a different vaccine from another country.
But it's not our core program.
No.
And I suppose the other key
out
thing,
of necessity.
Yeah, it's not scheduled. So if you're going heterologous, you need a prescription because it's off license. So that's the key point. So with Jane, with the Pfizer, the IMAC guideline says check the volume before removing the needle. With the AstraZeneca guidelines, it says remove the needle from the vial, then check the volume. Is there a rationale for difference in the process?
Yes.
I thought it was the other way around.
We're matching the two together. So actually we've been given feedback that actually it makes more sense to check the volume while the needle's still in the syringe. We'd always imagined people would do that, but then we were saying cross-check with somebody else, so get somebody else to check that your volume's correct. Actually, what we're saying is they might as well check while you've still got it in the syringe, and then if they say, actually, I think you need a little bit more, you can draw that little bit more in. So watch this space over the next day or two. We will be having an updated Pfizer vaccination preparation list. It's not that we're changing the way Pfizer's drawn up at all. It's just we're putting a few more details in, and little things like that are being addressed where there is a bit of a mix of information.
Yeah, so we've got a few questions through about prescribers on site. So one of the DHB site leads I know says that I don't think our local sites have prescribers on site, unsure it'll be possible in the current climate. Will this rule our sites out? I've had
My understanding is that the DHBs did specify they wanted somebody to be available, and that was one of the criteria, but I am not involved in the rollout. It's only what I've heard. One thing they are looking at is the legality of setting up standing orders, but because they are off-label use, they are taking advice from Crown Law around this at the moment, and I had hoped to have a definitive answer for the webinar today, but unfortunately they haven't had an answer back yet. So for the moment, the Ministry's recommendation is that it does need to have, you do need to have a prescription, and they are saying that the sites they're setting up, certainly at this stage, do need to have prescribers available, so it will limit the number of sites.
Yeah.
There may be some looking at telehealth and whether the scripts could be written remotely or something like that. There are other permutations that need to be looked at, because obviously we do want to make the vaccines as accessible as possible. Same issues around the dose for immunosuppressed as well. So that's also being looked at.
Yeah. So I know a local DHB is telling patients, you know, if you want AstraZeneca, you have to go away to your GP and come back with a script. They don't have a clinician available at our sites either. So I think that's going to be a more common thing. But at least Jane mentioned maybe it's something that'll move in the future, but right now you need a script. So there are a number of pharmacies able to administer AstraZeneca vaccine. Will these pharmacies be able to facilitate a script for the patient without referring back to their GP? Pharmacists aren't prescribers unless they're a pharmacist prescriber. So I'm picking not, unless that telehealth option comes in. Have you got anything else to add, Jane?
No, as I say, my understanding was they were not being commissioned to deliver the AstraZeneca unless there was a, but that may have changed.
Yeah.
That's the challenge with us giving the technical advice rather than the practical advice. I did invite somebody from the Ministry to come and join us, but unfortunately they were unable to.
Yeah, I've got somebody has reported that at their DHB site, they're opening their site without a prescriber. The expectation is that the patients will approach their GP for a script first. So thank you for that feedback. Egg allergies. Joan, any comments on egg allergies?
Yeah, no, I don't think it's got egg in it. So
yeah, yeah. Another question regarding the scripts, to just clarify, so those who walk into the vaccination clinic, as a lot of our patients do, who request AstraZeneca can have it, but must complete a consent. But if they have had Pfizer as a first dose and want AstraZeneca, they must see a GP at their cost for a script. What if they have no access to the internet to book? So I suppose just clarifying, when do you need a prescription?
So they'd need a prescription if it's a mixed schedule. They wouldn't need a prescription if it's the first dose. They've decided they preferred to have AstraZeneca instead. And there's still this issue of them. The Ministry was saying that they didn't want them to have to go to GPs to get prescriptions. So, you know, unless the guidance has changed there, but I do understand that there will be funding associated with any visit that is necessitated to generate a prescription.
Yeah, so if the patient was holding out, they've had no doses of Pfizer and they're turning up, they're like, yay, AstraZeneca's here and it's their first COVID dose, they can just get, that's approved. 2 doses of AstraZeneca is approved, so they can get it if they've had no history of COVID vaccination. So they're easy. Just when you're mixing them.
Yeah, just a consent form. Yeah.
Yeah. Okay, a New Zealand citizen from Vietnam who's had 2 doses of AstraZeneca coming back to New Zealand, do they need a booster dose, and should they stay with AstraZeneca or move back to Pfizer? What would you do, Joan?
Well, it depends on their age and how long since they had their 2 AstraZenecas. You know, young people, there's no rush to have a booster. But I think the preferred booster in the UK is Pfizer, to be honest.
Yep. So in that case, you'd need a script because you'd be mixing.
True.
If you went
yeah,
for
but
booster,
probably not
Pfizer.
You know, they could probably have either.
Yeah. Yeah. Is the patient, if patient is eligible for 3-dose schedule, so we're talking about severe immunocompromised, do we give the 3rd AstraZeneca 8 weeks after the 2nd dose? So we're looking at severe immunocompromised, 3rd dose. Can you do Astra? And what's the spacing?
Well, again, if they're immunocompromised, you do want to try and get them protected in this current climate. So, you know, they could have 2 doses 4 or 6 weeks apart, and then their 3rd one 6 to 8 weeks after the, well, 8 weeks after the 2nd, I suppose. Yeah.
Mm-hmm.
But I think, again, that's a very individual thing that could be varied a bit, brought down if there's an urgent case for it.
Yeah. So there's another question regarding funding for GP funding available for AstraZeneca.
I think that's one we're
much.
just going to have to say, look, you're going to have to talk to your DHB leads on that one and direct to the ministry. We're not the ones that are involved in that. And it may be that their original plans for rolling out the vaccine and having prescribers on site are not working. It sounds like that's not the case, and as I suspected. So unfortunately, we can't comment more on that. Yeah. Except to say our understanding is if a prescription's needed, it would be funded.
Yeah. So another question regarding boosters, will there be a recommendation for a third dose of AstraZeneca? If so, what would the time frame be? Would that be 6 months too? So the patients had dose 1, dose 2 of Astra. Will they be, do we boost them with Astra as well 6 months down the track?
Well, I think we've just talked about that. And I mean, to be honest, it's something I haven't quite thought about yet or read the data on. So sorry,
if they're getting first, if they're getting dose 1 and dose 2 of Astra, 6 months later, they need a booster.
Let's think about it in nearer 6 months.
Yes, that's right.
I don't even know if
watch this space. We're not there yet.
We may have another vaccine available by then. So, for the moment, these patients, might get 1 or 2 from abroad or healthcare workers that have had AstraZeneca that would need boosting. And our recommendation is that we're boosting 6 months after completion of the initial schedule. But we haven't got formal guidance on that at the moment.
Yeah. I'm just showing this page here. This is a really helpful policy statement document that the ministry have outlined. And in here, they've got where you need the prescription, how you combine them and things like that. So I would refer people to look at this.
What does it say about boosters, Olivia?
Now, boosters, I found.
It does mention boosters.
It mentions on the website here, the Pfizer vaccine is the primary vaccine being used in New Zealand for boosters, regardless of which vaccine was used for earlier doses.
Yeah, it's the same in the UK, I think.
Yeah, but it does say boosters can be used if you're using AstraZeneca, and the one you've just shown, if you're using AstraZeneca,
there was a booster table.
There is a booster table there, and it just reminds that you need a prescription if it's a mixed schedule.
Yeah, so you will need a prescription when using AstraZeneca as a booster. So there you go. So please go to this document. It's brilliant. It's really helpful. It's practical, which I like.
And I'm pretty sure it says in there about the 6 months as well.
Yeah. Okay, thank you, Lisa. So we might wind this up because I'm conscious of time, Jane. With regards to breastfeeding, saying to a patient it should be all right may not be so reassuring to them. How do we go about providing more confidence separate to our current knowledge?
Oh, well, it's in the UK guidelines and that it's safe in breastfeeding.
Yeah.
And it's been widely used internationally. If there had been a problem, it would have been picked up by now.
Exactly.
But certainly it's clearly written in other countries that are using AstraZeneca vaccine as a main vaccine.
Yeah, so somebody has asked if we can put resources on our website. Joan's studies that she referenced comparing the incidence of symptoms from the COVID versus symptoms from Pfizer and AstraZeneca. So we can look at adding a link to those studies as well on our website because it was very helpful for her, she reports. Although rare, could we suspect that TTS in New Zealand with AstraZeneca might have poorer outcomes since clinicians here are not as practiced managing the side effect than in Australia, where AstraZeneca was a first-line vaccine. So someone else asked, does someone let ED know about these side effects and is there protocols in place?
Well, I've written something going out to the GPs today, and I would hope that doctors, we're trying to disseminate the information widely.
Yeah.
Health pathways and other channels.
Right, I think we'll call it a day then. If anyone has still got a burning question that we haven't managed to address, please send them through to 0800 immune at auckland.ac.nz and we'll happily respond to them there. And we have taken a note of all the questions to inform our question and answers on our website. So thank you all very much. Thank you, Joan, for your really interesting presentation. And thank you to the guys supporting in the background with all the questions. I think we have managed to get through the vast majority and we haven't run over by too much. So here, everybody, and have a good afternoon. Bye-bye.
Bye.